There you go.
So, so yeah, Sharon, pronounce your last name for me.
It's Lemoyne.
Oh, I love it. Everybody, we have Sharon Lemoyne here, and she's a practitioner, Washington State in the Seattle area, and we're just talking freely about the healthcare system and what it's like as a practitioner. Sharon, continue with your thoughts because I think that was really amazing when you're talking about you driving past the hospital and your initial reaction.
Yeah, so my background, I've worked in emergency medicine for 25 years. I now own and operate a medical practice here in Gig Harbor, Washington. And we were talking, my services include primary care. We specialize in menopause and perimenopause care, really health and wellness overall. So it's very fulfilling. But, the other day I was driving by the hospital that I used to work out downtown Tacoma, very urban area. And I had this anxiety come over me that I really was not expecting. And I just paused and thought, and I've been so thankful that God has put me in a place now to do the work in a private practice. But when you reflect back on that level of stress working under the constraints of corporate healthcare, you have such a different perspective when you step away. And there's so many challenges for providers and medical care, medical, providers, but for the patients as well. And so it's just a God-given gift to be able to practice medicine and serve my community in the setting I am now and bypass corporate healthcare. I mean, that could be a whole podcast in itself and
Oh,
how patients want so much more than what they're getting.
I had to step away from MHMRA in Houston. Houston's got 8 million people in the Metroplex area. You can imagine that scenario. And we had four clinics. I was in a Southwest Houston portion, which is gigantic. And so, we had to take cases, anybody that came through the door. And, so we're dealing with a huge immigrant population, people from Pakistan, all over the world,
Yeah.
who maybe barely spoke English, maybe not. We had to get translators all the time, just like in any major hospital. And in our clinic, we triage patients, and we had a billing department, anything a regular hospital would have, pretty much, except for staying overnight and so forth. We had psychiatrists and all of that, and we even incorporated dentists, general practitioners to take care of other health needs because we saw a need. The problem was the machine.
Right, right.
when the people first come through the door, they're faced with the billing department and the business office. They had to get through all of that first, get qualified because not everybody has money. So if you didn't
Right.
have insurance of some kind, then they qualified you under that program that the state of Texas provided that money for you, and also for prescriptions too, because we had our own pharmacies in our own clinics. Big deal was the back office, the numbers grind, uh, billing.
Yeah.
Billing it was horrific because every practitioner had to produce, and they had productivity standards, and all of those things
Uh-huh.
came from on high.
Yeah. Oh,
from
yeah.
the from on high, as I call it. And if you're not meeting, it didn't matter how long you'd been at the clinic working, if you didn't meet those standards for whatever reason, patient cancellations and all kinds of
Yep.
stuff you can't
Yep.
control. People just abandoning the process. We were accountable for all those numbers, and so every Thursday they would give a report, and they would send it to everybody in the clinic. Your
Compare you against your peers. Yep.
everybody.
Yep.
And your clinical team lead, every team, we had 5 teams in our clinic. And then clinic to clinic, PMs from one team would compete against another team and across the city. It was ridiculous. And so that became, I think, a primary driver. They even do it the psychiatrists that we had, and it was so bad to where how much billing could we do? And I couldn't believe the machine behind it. And then there was this piece you mentioned about patients not getting the care.
Right.
Um, when you as a clinician as a therapist has a client load of 100 people, just you alone, it's very difficult because you've got to do things like housing. They had something called an NASA. I'm not sure if you, Sharon, have ever done one of those for the state of Texas or any other states, but they have an NASA called an ANZA, and it's a needs assessment
Okay.
that we had to do. Everybody had to do it, which is crazy. It's just so many layers to it. The documentation
Mm-hmm.
was for every case,
Right.
given what type of case, extreme. You might have to write 3 or 4 notes for one patient, and they're all due within 24-hour turnaround.
Yeah.
So it was insane. Plus, they kept spreadsheets on you. And then what about this, Sharon? Utilization and review. Did you
Oh
have
yeah.
that?
Oh yeah. Oh yeah.
How
You know,
many
it's
nightmares
interesting.
did you have
Uh,
behind that?
Oh, I could tell you stories. I could tell you stories. You know, it's interesting when I think back on working emergency medicine, when I would start my day, I felt almost like an air traffic controller. You've
Mm,
got everybody coming at you at different angles and you're trying to manage everybody. And at the same time, you've got the people above, like, see these patients, see this one, see, hit your metrics. And I mean, you're seeing people in crisis mode.
yes.
And how do you take the time to acknowledge their true needs when as a provider you have so much coming at you and there's just it's not sustainable.
Mm-mm.
And I think for provide and that's why I'm such an advocate to talk to providers to step out of that corporate healthcare setting and open up their doors. There's some,
Yeah.
I mean, phenomenal healthcare providers. We all want to do well by our patients. It's a little scary to go into the
Mm-hmm.
business side of things, but they
Mm-hmm.
know medicine. Put your confidence in the medicine and the skills you have to give your patients. Open those doors, take a little bit of time to learn the business side. But when you can spend the time with those patients, it is so much more rewarding. When I have brand new patients come in, they get a full hour with me,
There you go.
one on one. I am learning about them, their family, and the layer to it now is to bring our faith into it. If I've got somebody in crisis and they need a prayer, I'm not looking over my shoulder, afraid I'm going to get fired.
Right.
I can ask them, and we don't push our faith on all of our patients. There's always those Karens out there that are gonna, oh,
Yeah.
telling your patients, which is kind of, I just chuckle. Um, but the patients so need that. They need that validation in their symptoms. Just the discussion alone is so healing before we do any intervention.
That's it.
Yeah. So it's so funny too because never say never to God. He'll just laugh at you. Um,
Huh.
being in emergency medicine, there was a little bit of ego that was involved where I thought, oh, I'm going to do all this really cool medicine and I'll never do primary care. How boring is that? And boy, God showed me and put me in this scenario now. And let me tell you, it is so much more rewarding than I ever had in my emergency medicine career to see changing lives and seeing people truly being healthy physically, mentally, spiritually. It's a gift for sure.
I said the same thing 10 years ago when I kind of first started my journey with mental health care up in Virginia in Appalachia.
Oh,
Uh,
interesting. Okay.
yeah, talking about interesting. I,
Yeah.
I did my master's thesis on trauma, matter of fact, early childhood trauma.
Okay.
So I specialized in that. And so I saw quite a bit of it up there. And I was running anger management groups as a student and, post graduation and all that, amongst other things, IOP groups and stuff. And I saw a lot of things, with people in Appalachia with drug use and so forth.
Mhm.
But how it all kind of filtered back to some kind of early childhood trauma. There were things that would happen, and I would hear stories from my clients up there about how they were abandoned, neglected, or sexually abused, or physically, just literally beaten up by
Yeah.
their parents or their uncle or somebody, and emotionally abandoned. I see that down here in Galveston right now with just about
Right.
every case I have, in on the Christian counseling side of it. And it's sad how these dots connect. And when you look at in emergency medicine piece, when I used to work in the mountains, you never looked at you didn't have time to look at that. You know, it was
Right.
it was very mechanical. We had numbers to keep,
Yep.
i.e., they used to clock us how much time do we spend per patient, and our
And what was that number? Like, what were you allowed with those patients?
2 hours max. And when
Yeah.
you're when you're dealing with emergency room triage
Right. Right.
and you're dealing with medical doctors and you're dealing with other scenarios that you
Mm. Oop, I think I lost you. Are you there? There you are.
I apologize.
That's
Somebody
okay.
called me
I
and
was like,
interrupt.
oh,
But when you're dealing with, all those factors, you don't have time to really dig into the minutia as to why this patient is there. We had a lady that showed up. One case, she was already identified as borderline.
okay.
And that's kind of one of those things to where a lot of systems will look at a person like that based on the previous diagnoses and just basically dismiss them because the system says they're not treatable. They're resistant to treatment. So therefore, insurance companies won't reimburse for that.
Wow.
Yeah, that's a fact. And so, you're faced as a clinician uh, because the MD is going to refer to you,
Right.
as mental
Right.
health, and you have to make the decision, and it's going to have to be what the system says. That means you have to discharge them,
Mm.
no matter what their symptomatology, unless they say they're suicidal or
Mm-hmm.
homicidal. You see,
Mm-hmm.
and so it's so all these nuances, right? But
Right.
I tell my clients now and other clinicians, and I got a student that I deal with. That I say, this person is the way what I use is I said they're symptomatic. They're symptomatic. A lot of times we look at diagnoses because people push diagnoses. Medical
Right.
doctors, clinicians push,
Because that's what pays money.
yeah, what's their DX? But I
Yep.
was I
Yep.
was trained not to diagnose immediately.
Mm.
Maybe take 2 weeks, to see what's driving psychoanalysis here. What's driving this symptomatology?
Right.
There's a driver. What is it? And so, but the system doesn't give. They don't have. They don't allow for that. In my old clinic, we had uh, she was a psychiatrist that would come in as a reserve when other psychiatrists got sick. And so she was retired. And she
Okay.
came in there and I love that woman because she came in and she says, Mr. Times, I don't give a blank. I'm gonna treat these patients and I don't care how much time I spend with them. And I'm like, I love you.
Yeah,
Because
exactly. Exactly.
she would spend an hour, sometimes two, and she'd be there 8 o'clock at night writing notes.
Mm.
But I loved it because she corrected at least 3 or 4 of my patients' diagnoses that I'd been begging to get changed because I knew what they were. But being
Right.
being a mental health clinician, And then you're dealing with a psychiatrist. Who trumps who? You see, you get all that business
Right.
to deal with.
Right.
So it's like, but that was the only psychiatrist I've ever met in 10 years that was like, had that perspective.
And I really think those types of clinicians are the ones that really need to step forward. And we all
Mm,
need to not buck the system, but really speak out and advocate for the patients. Um, I think the patients, with all the information out there and social media right now, they're coming in pretty educated. They've done some of their homework. They
mm-hmm,
know what they want from their providers. And we have all seen as this progresses, corporate healthcare in general is
mm.
it's just I could say a lot of things, but it's very sad to me. And I think a lot of providers they don't have a choice.
No,
If you
they
want to
don't.
show up at their job, they have to comply by these rules. And that's where I'm saying, walk away. You can give good quality care
Yep,
in your own setting, of course, working within your scope. And
yep,
I think there is a trend, quite honestly. I think that fear of, traditional having a job, punching a clock, the retirement, all these things are security in your career and finances. But obviously, if you've got faith and you believe in God that He's given you this gift and you're going to use it, the blessings will follow. Like you have to have that faith. But for a perspective of just giving quality care. I can't say it enough. Step out on your own. Open up these ma and pa type medical providers. We're going back to the old school days, right? Where they
yes,
know you, they know your family, they know you just
yes.
went on vacation last month and you come back, and there's just that personal relationship. I go into town and it's so funny. People will say hi, and my husband's like, "Oh, are they your patients?" I'm like, "Yeah, it's great." And we go to church. I treat half of them. It's definitely a sense of community, but for professionally speaking, it's something I never saw coming. I cannot speak enough because then we're not so bound by these corporations and insurance companies that's so just driven monetarily. I hate to say it, but I truly don't think they have the best outcomes
No,
in their best interest and
no,
intentions.
they don't. They can't because, you start looking at, it's just a number scenario. I was shamed in my old, office there with the MHMRA because I wouldn't just discharge copious amounts of like half of my caseload and stuff. Because
Uh-huh.
my thing was, what's going to happen to those people when I do? Because I know what
Right.
I do for them. You know what I mean?
Right.
Like I've saved a lot of people from getting evicted. You know,
Yes,
stuff like that.
truly.
And
Making sure their basic needs are met.
yeah, make sure they're fed, giving them,
Yeah.
getting them food stamps and just all kinds of stuff. I was, what's going to happen to those people? You know,
Yeah.
so there's a greater burden. And then I tried not to sit up and worry about them, my patients, because yeah, but it was one of, I mean, you're a human being and there's things that you understand how things are when you got clients who barely speak English. Yeah.
Right. Right. Right.
Just they speak Swahili only. You know what I mean?
Yeah.
Or, some Middle Eastern language and they don't really understand the system and they're at the mercy of the system. It's like, yeah,
Yeah.
it's a lot of dynamics there, and they have mental disorders because they're seeing you. So it's like,
Great. Oh, can
eh,
you imagine being in another country, not knowing the services, not speaking the language, and
mm-mm,
being in a true crisis? I
mm-mm.
can't even imagine.
No, I mean it's an unbearable pressure, and the system is set up. I just didn't like it because you're going to provide housing like HUD funds, like Section
Mhm.
8 or whatever. We had
Mhm.
something called 811 housing for people who had mental disorders. Well, these people really need it though. Like they can't work because they're hearing voices and all kinds of stuff.
Uh-huh. Uh-huh.
And the system was unforgiving when it came to Social Security and how they function. You have to apply 15 times. I'm being hyperbolic, but you get the
Yeah.
idea.
Yeah. Yeah.
And just lots of barriers for them. I've had people from Venezuela who were running from at that time, who was that guy?
Oh,
Castro,
that just,
whoever.
yeah, uh-huh. Yeah, I know who you're talking about.
That guy. Yeah,
That
you
they
got
just, yeah, they just got assassinated, right?
yeah, you
Yeah,
got all that kind of stuff, and you're like these people like are at the mercy of the system,
the
you
government.
know,
Yeah, yeah,
and they're trying to get established, and they don't really want to be here, but they're running from crazy people. So you're dealing with a lot of things, and the system's like, let's treat them like cattle, and let's treat all your practitioners like cattle too.
exactly.
And I've heard, I don't know, I've heard people committing suicide and stuff as practitioners
Yeah,
behind this stuff. This is
because of the
sad, but it's
pressures. It's
true.
very sad. Yeah.
I myself, I can speak for myself. I don't mind disclosing this.
Yeah,
I've experienced medical problems from being in this field because
absolutely.
of, well, you mentioned anxiety before, but passing by the hospital and that. But I'm pretty sure I got anxiety from dealing with all this stuff for years without really any outlet because we're
Mhm.
kind of like islands, unfortunately. And
Right, right.
and I told Sharon, I laughed, and when I was at the other location, with the MHMRA with other clinicians who were there. And I said, we were doing notes at the end of the day, and I said, it's a shame when we have to start taking the same medicine as our patients. And
Right?
everybody in the room busted out laughing because
Yeah,
we all understood that.
yeah. You know,
That's got to
and
be addressed.
you hit on a great point because that was where my anxiety was coming from the other day when I drove by. Because I now know working in the wellness and longevity, really diving into what is happening to our bodies when we're not sleeping, when our cortisol levels are elevated, the
Mm.
that anxiety level that you're living at every day, plus factoring in midlife, hormone
Mm-hmm.
fluctuations. We are advancing the aging process, the high cortisol. You gain weight. Now you're pre-diabetic. Now you're fatigued. Now you don't want to work out. What does that do to your mental health? I mean, it
Mm-hmm.
is a huge cascade. And I honestly think that's where my anxiety came from the other day because I see where my personal health is so much better in my mid 50s now than I was in my 30s and 40s working in emergency medicine.
Mm-hmm.
And to have that palpable difference in how I physically and mentally feel, that is another huge message to our providers. I'm a big advocate for setting the example to our patients of
Mm-hmm.
that healthy lifestyle we should be living. But
Mm-hmm.
when you're under those constraints like you and taking care of the mental health and taking care of so many people. How do you even have time to process that on your own? And this is what I worry about with my daughter who's going into the field. She's a
Yes.
beautiful, kind person. And I'm like, oh, I don't want the world to get to her and make her, feel that stress, but you carry it with you.
Yes, you do.
Yeah. So I think the discussion really needs to be more and more on providers career wise, where do they want to go? And physically, mentally, how are they taking care of themselves so they can give the best example to their patients?
We talk about it. I remember them touching on this in grad school, but when you start really looking at the outlook and looking at the big picture, and no school, I think, medical school, grad school can really teach this well enough. It has to be, I think, experienced because I mean, you think about it. I don't know about your program, but mine was replete with all the clinical stuff. You know,
Right, right.
diagnoses and treatment and all this kind of stuff. I mean, it was already a lot of information for you to absorb. And
Of
then you had
course.
your clinical stuff, your practicums, and all that.
Mhm.
It's very complicated. So I don't know if there's room, but they did touch on the wounded healer piece, about, us being the people who, are seeking out to heal the wounded, yet we ourselves are wounded.
Are wounded. Correct,
Yeah,
correct.
and of course self-care, but it's like you said a moment ago. And I tell all my clients, I put it in their treatment plans. Even now, hey, you need to do self-care. How much self-care have you done? What have you done? But yet,
Right.
I'm not doing it.
Yep.
See,
Right.
I'm
Right.
not doing it. And I had
Right.
to force myself. I said, you live on this beautiful island with these beaches and stuff. You got to
Yeah.
get out there and walk.
Yep.
And
Yep.
when I do it, Sharon, I feel better.
Yep. Yep. I have this conversation often, especially with my younger population, my patients in their mid 20s, early 30s, they're coming in with depression. And I
Mm-hmm.
and I ask them, okay, what's your lifestyle like? Some of them are living in mom's basement playing video games all day,
Yeah.
and they haven't seen the light of day in months. And I'm like, okay, like hang on. Let's
Yeah,
just do the basic stuff. Go do a 10-minute walk. Get out there and move your body, get the blood flowing, get some sunlight, the
that's
basic
it.
stuff. That's what drives, my health journey because I don't want to be a hypocrite.
Right.
And it's a
Right.
very fine line to walk, to
Yeah.
give of yourself to your family and your patients, but to make time to do the work, it's tough. But I think us talking about it, it does motivate us as providers to, yeah, like you said, a simple walk on the beach can make such a huge impact on our mental health and
Yeah.
how our day actually goes. Starting the day with prayer. I've
That's
talked to my
it.
husband with this. Just that sets the tone for the day.
That's it.
So, yeah, it's pretty, and it's pretty, it's felt among many different populations, and almost everybody has that struggle of finding that balance. So I think it's an important conversation.
Dr. Bessel van der Kolk talked about it because he specialized in trauma. Still around, still doing that work after these many years. But he expressed that the body retains trauma and throughout its lifespan.
Hmm.
So we know that. We know that it does. And where our prefrontal cortex, is our captain, our seat of our, consciousness. And we, usually try to rely on that. But the things that happen to us in our lives that causes us to push our memories, right,
Hmm.
down until we don't remember. Our brain has these incredible defense
Yeah.
systems where we have this amnesia effect where we don't
Yeah.
remember certain things, especially early childhood
The
stuff.
trauma. Yeah.
And so we push that into our bodies. And so we develop chronic illnesses because of this stuff,
Hmm.
and all of that really has to be addressed also as root cause. I like root cause stuff
Yeah. Me too.
because
Me too.
because you could be systems basically about putting the band-aids on it. Let's diagnose, put a band-aid,
Exactly.
send you out of the ER or wherever.
Yep.
That does no good. you know
Yep.
you could triage, you could do that, but find out what's really going on with people.
Well, and that's why I love the transition I've made because corporate healthcare, they're making money off of big pharma and prescribing
Yes,
medicine. And
yes.
I actually have a bell on my wall here in the office. When we get people off of medicine, they ring the bell.
Oh, you go, girl.
Yep. And it's such a huge piece to
Oh,
um, look at root causes, and it just changes the narrative. And again, our patients are getting healthier, and big pharma is making less money off of them. And
this
yeah, that to me, that's a win.
I call this generative because you've been productive, juxtaposed to regressive.
Yeah. Yes. Yes.
You're not decompensating,
Right.
and too many times the medical systems, they're all about decompensation,
Mhm.
because I mean, if you think about it, the whole society is about that. You buy a car and it doesn't last as long as the other ones used to. They break down
Right.
more frequently. That
Right.
the system makes more money out of you going into. You can't even work on your own car anymore.
Right. Well, I was just going to say more so in the last couple of decades. I've got elderly patients that have the same washer and dryer that's been going for the last 50 years, but you buy
Yeah,
a brand new one now and you're replacing it in 3, 4 years.
yeah.
So yeah, that's intentional for sure.
And so is healthcare. I
Yeah.
remember my old CEO. I should have known something was up when he said this. He says, I'm all about numbers. And that should have caught me. I mean,
Right.
it just went over my head. But looking back on it, I'm thinking, you're a mental health provider. Why are you saying it's all about no? It's the corporate stuff.
Exactly. Exactly.
And what about people? You know, isn't that important? No, they don't discuss that. They don't want you to think about it. Chris, you're spending too much time on unbillable things. You have to hear this
Yep.
stuff.
Yep. Yep. You know what big takeaway for me was COVID. And that's about the time I was
Yeah.
starting my business and slowly transitioning into the business and away from emergency medicine, but seeing how the monetary drive in how that was dealt with. Initially when COVID first broke out, the ERs were, you could hear crickets. Everybody
Yeah.
was so afraid to go anywhere, and they were furloughing providers.
Wow.
And this was brief, obviously, but everybody was taking a little bit of a financial hit. And I kept thinking, what's our CEO? Is he taking a financial hit through all this?
No, no, he ain't taking a
And
hit.
then I found out that if we saw so many COVID patients, and I can't speak exactly to the metrics, but in a nutshell, by seeing COVID patients, providing them services, giving them vaccines, and so forth, there were government dollars sent to these bigger corporations.
Oh.
And seeing that that did not trickle down to the frontline workers, that stopped at the administration level.
Mm.
To me, that was a big takeaway. That,
Mm.
if you're going to take these government funded dollars, spread it down to the people that are blood, sweat, and tears on the front lines taking care of these patients. And so that really, for me, just was, it's just kind of gross how it all went down. And I'm again, extremely blessed and thankful and grateful to not even have to worry about that anymore.
That's amazing. All right, you reminded me just now, my PM, she was dogmatic for sure, but there's one thing she did do that I appreciate during all of the COVID stuff, and well, even before COVID. Uh, she would tell the people on high, the VPs and so forth, and muckety mucks, because they never came to our. We had giant 12-story building. The clinics were on the first three floors,
Okay.
and the first two rather, and all the higher up people were on floor 12 and 8 and 10. They were in a different world. And
Mm-hmm.
so something happened to where our PM is like, hey, if you want to know what's going on down here, you need to bring yourself down to these floors. You need to come
Yep.
to the clinic. And that's when we start seeing every now and again, a couple of these MDs who are executives
Mhm.
would do intakes. Now that was always crazy because you're dealing with a very symptomatic patient.
Yeah.
Somebody been off their medication or never had it, maybe right
Yep.
out of prison or whatever,
Right. Right.
and super psychotic or whatever, and they're coming in to be triaged. So we have to do intake. Now, the way they set it up was the clinician like me, I would sit there, and during COVID, the people on high would like remote in.
Oh, how funny.
Oh
Yeah.
yeah, yeah.
Yeah.
They
Of
they work
course.
from their houses, like in
Yeah.
Sugarland and stuff. They wouldn't
Yep.
even, they didn't even come to. They didn't even have to come. I had to show up, but they
Yep.
didn't have to. So I was like, oh yeah, that's just great.
Yeah.
Yeah. But there are other, even before the COVID, they would show up, and I'd be in there in the doctor's office with the doctor, and we've got a very symptomatic patient there with their mom or their
Uh-huh.
wife or whoever,
Uh-huh.
and the doctor would make all kinds of mistakes, all kinds of psychiatric with medication and all kinds of stuff, and I'm having to correct the situation and right then.
Right.
And it was so bizarre. And I'm like, I'm not even a medical doctor, but I've been trained in certain types of pharmacology. because
Sure.
of what I do. And I'm like, you can't do that. You can't give them this and that, you can't do it. And I'm having to be very diplomatic because of
Uh-huh.
their medical doctors and I'm
Sure.
not,
Sure.
right? So I'm walking a tightrope and they got the patient sitting 3 feet from me. See, they don't
Uh-huh.
know what's going on. And I'm like, oh, doc, you know, how about this instead of that?
Yeah.
See, oh, you know what? You're right. Or they're acting some. They're not diagnosed. The patient's isn't diagnosed, and I'm helping guide the diagnosis because the MD's totally missing the whole. It was all the time this happened,
Yeah.
or,
Yeah.
or the doctor can't communicate with the patient. It's just constant stuff, and I'm like, you know what? A, they don't pay us enough, and B, these doctors trying to stick their toe into the flow, as they used to call it.
Yep. Yep.
That don't work. You're out
Yeah.
of. You hadn't sat with a patient in 20 years.
Well, and then during COVID, make them come down with their suit on and put them in a papper and a gown and a mask and a hat, and then they can sweat there
Yeah,
while you're trying to do the work.
no, they're sitting at home, and
Yeah.
and they're doing telehealth. I'm like, that's crazy. The nurses, do you know? Oh, I gotta go. Do you know the nurses in our department, in our clinic? We had like 5 nurses and then a nursing supervisor. Do you know all the nurses caught COVID at the same time?
Interesting.
All of them. They were gone for felt like a month. And that happened twice. And this is like before they had the vaccine out.
Right, right.
And you know, I caught COVID towards the end of mine. This was the coup de grace for me, is why I just said I'm done.
Yeah,
When I got COVID, I was out for 4 or 5 weeks.
yeah.
And the only thing that saved me, I think, was that monoclonal antibody thing that they gave Donald Trump.
Okay. Oh, uh-huh, uh-huh.
That saved my life, I'm pretty sure, because I was on death's door. And when I got back to the clinic remotely, I had to hear from my supervisor, my clinical team lead, that I'm a bad clinician because I didn't wait a minute, I didn't keep contact with my patients while I had COVID.
While you were laying in the bed near death.
Yeah. I said, are you out of here? I said, are you serious? And then I had one client who definitely was borderline, was like crying out because I abandoned him. That
Yeah,
is not true. I texted all his clients and told them I had COVID and I didn't know how long I was going to be. You see, he had all of that craziness.
yeah.
And I said, I'm done. You know?
Yep, yep. I think a lot of people have very similar stories where COVID was the catalyst for making changes.
Oh, Sharon, this has been a beautiful I enjoyed it. I almost call it a session. A
Yeah.
session.
Oh, it's a
But
session, of course. I feel
yeah,
like it was a session. I feel good.
me too. I enjoyed this very much. Tell our audience, for the people who want to get in touch with you, how can they
Yeah.
reach out to you?
So obviously I have my practice here just outside Tacoma, Washington. We're about 45 minutes outside of Seattle. And I really try to do a lot of public speaking, educate, advocate, and validate patients. I really just want to give them the best information to navigate their health. So I have my YouTube channel, Health, Hormones, and Faith. And then, of course, Instagram at the concierge NP. And so we're doing some really great things in our area, and I just love any opportunity to share stories and really help advocate for both patients and providers out there thinking of making changes. So I certainly appreciate you having me today.
I enjoyed you. You take care. God bless.
Thank you.